The lecture today will be about antibiotics in periodontal therapy. We will start with the terms used in periodontal in antibiotic therapy in periodontal. First, antibiotic, it means the use of medication to kill or suppress the multiplication of microorganisms, but it should be in a concentration that is relatively harmless or not harmful to the host tissue cell. Therefore, we can use it to treat infectious disease. So let's come to periodontitis. Is it infectious disease? Yes, of course, it is an infectious disease, but it is different from other infectious diseases in some characteristics, that it has different types of pathogenic bacteria, not only one species or one type of bacteria. So it has a different types of or different species of bacteria that can cause periodontitis. It can be treated by antibiotic, but we have to take into account that antibiotic cannot penetrate the calculus and dental plaque, because this is a thick accumulation of bacteria, cannot be penetrated by antibiotics. Therefore, we have to remove calculus and dental plaque mechanically. So it is mandatory to remove the dental plaque and calculus before starting with antibiotics. In general, antibiotics can be classified according to different characteristics. For example, according to the mechanism of action, we can classify antibiotics into bacteriostatic, which means that this type of antibiotic or this type of agent will stop the multiplication of microorganisms, but not killing it. Or bactericidal, which means killing microorganisms in different ways, either suppressing the photosynthesis or protein or DNA, etc. According to the range of susceptible microorganisms, we can classify antibiotics in narrow spectrum, which can act on a very limited number of species of bacteria or microorganisms, or a wide spectrum. According to the pathogen affected, we might classify it into antiviral, antibacterial, and antifungal. Therefore, antibiotic, it covers all of these three: antiviral, antibacterial, and antifungal. And lastly, according to the origin, some of the antibiotics extracted from living organisms, and some of them are synthetic. Let's go back to the mechanical plaque control. As we said, it is essential to remove the dental plaque and calculus mechanically by using hand instrument or power instrument. But that doesn't mean that it doesn't have any limitations. There are some limitations in the mechanical plaque control. First of all, it needs a lot of time until we finish the removal of all the calculus and dental plaque, and then wait for the results. Second, it requires a high level of hand skills or manual skills, dexterity. And third, it needs adequate motivation for the patient and for the dentist as well. Microorganisms cannot be removed from all the infected sites, sometimes because of the differential anatomy of the root surface, or the presence of concavities or lacunae, or even in the dentinal tubules. Sometimes the microorganisms can invade the dentinal tubules, especially in the exposed dentine from the root side. So we cannot remove it by the mechanical instrument. Therefore, we might use antibiotics. Substantial heart tissue trauma also might arise from repeated mechanical treatment. Therefore, we have to think about using antibiotics after mechanical treatment, or as an adjunct to the treatment of mechanical plaque. On the other hand, antibiotic therapy has limitations as well. It can be successful in treating infectious diseases, but these limitations might or should be considered. First of all, the resistance to antibiotics. As we said that repeated use of antibiotics can initiate bacteria that has a special mechanism to resist antibiotics. Disturb the delicate ecological equilibrium of the body. Using a lot of antibiotic therapy or continuous antibiotic therapy can initiate resistant bacteria, can increase the multiplication of opportunistic microorganisms that will lead serious infections that might be more serious or more dangerous than the infection that we are already treating it by. At the same time, antibiotic agents might have some toxicity. There is no antibiotic agent that is absolutely not toxic. There are always adverse effects to different types of antibiotic agents. Therefore, before we start with antibiotic regimen, we have to evaluate the benefits. Will we have a good benefit from using antibiotics in addition to the mechanical blood control, or there is no difference between them? We have to evaluate the difference, and then we will decide whether to use antibiotics as an adjunct therapy or not. So in order to treat periodontal microorganism or periodontal pathogenic microorganism with antibiotics, we have to think whether periodontitis is infectious disease. As we said, it is an infectious disease. However, it is different from other infections that might affect the body. The differences in that is, first, it is caused by commensal bacteria, but it is accumulating. The concentration or the number of bacteria is more than normal, so it is caused by that. Second, there is lack of massive bacterial invasion to the tissue. So in a true bacterial invasion, the bacteria will invade the soft tissue and multiplicate within the tissue, inside the tissue. In periodontitis, this is not happening, or at least to some limits, it is not happening. Usually, in periodontitis, microorganisms are accumulating on the root surface. There is a little invasion into the soft tissue, but not too much. And the host immune response is interacting with these microorganisms indirectly through the barrier, the epithelial barrier with the bacteria that is in the periodontal pocket, not inside the tissue. Actually, they are interacting with the products of these bacteria inside the tissue. Therefore, in order for the antibiotic agent to be effective in periodontitis, it should be available in a high concentration or in an effective concentration inside the gingival clavicular fluid or inside the periodontal pocket environment. Inside periodontal pocket, there is a large number of bacteria of different species. Antibiotic agents usually, when reached to the pocket in a special concentration, it might undergo inhibition or inactivation or even degradation from other types of species that is not in target. Biofilm formation in the periodontal pocket usually is like a defensive mechanism for the microorganism in this community. It it will resist it will resist the antibiotic therapy, and the mechanism behind this can be explained in different ways. First of all, the biofilm formation will limit the diffusion of the antibiotic agent. So the antibiotic agent cannot penetrate deeply into the deeper layers of the biofilm. Secondly, the second theory is that unequal distribution of the electrical charge. There are different electric charge along the biofilm. Okay, and this differences in the electric charge might inhibit the transfer or the entrance of the antibiotic agent to special areas of the of within the biofilm. Third one is that within the biofilm, because of the limited nutrition, bacteria will reduce their metabolism as a way to be in the community and reduce their metabolism to get survive. Therefore, this might also affect the antibiotic agent effectiveness. Some in vitro studies also have shown that there are some genes that will be triggered upon a bacterial attachment to any surface, for example, to the root surface, and this gene will be a special resistance against antibiotic agents. Now we will talk about the route of antibiotic administration. Usually, um, antibiotic can be administered in a systemic route or locally. In a systemic route, it could be intramuscular or intravenous, or maybe orally, or we call it POs or PO. While the locally, that means we will use it to the local area like ointments, drops, creams, etc. To be used in periodontal therapy, we usually use orally as a systemic, and locally delivered in different ways. But the problem here, if we are using the antibiotic agents in the systemic route to orally, that means only a small proportion of the antibiotic agent will reach the subgingival area or the gingival particularly. And as we said, to be effective, it should have a high concentration for a longer time, a high effective concentration for a longer time. But if we use it in systemic routes, only a small proportion of the antibiotic agent will reach to the subgingival area. In addition to that, we might see an adverse drug reaction, which is are of great concern in oral administration. It requires also good patient compliance. While in using locally delivered routes, the antibiotic to be effective, it should reach to the base of the pocket. Therefore, using mouth rinses will not be effective as an antibiotic regimen for periodontitis because it will not reach the base of the pocket. And also, it should maintain a sufficient concentration for some time or for a long time. The locally delivered antibiotics in periodontitis can range from a simple pocket irrigation and irrigation inside the pocket to a special devices to introduce an agent with sustainable or sustained release of antibiotics. The problem we are facing here is that the gingival credicular fluid has the ability to wash out the agent any type of agent. The antibiotic agent that is inside the pocket, and it can the estimated half-life of the non-biting agent is about 1 minute. So it can reduce the half-life, it can reduce the concentration of the agent inside the pocket within to the half within 1 minute. This is the most important obstacle that you might face in using local delivery antibiotics. This diagram shows the difference between systemic antimicrobial and local antimicrobial. As you see here, that it is if we are using oral administration antibiotic agent, gastrointestinal system, and then to the liver, and then to the blood circulation, and then it reaches to the periodontium, and that will be a very important, and it depends on the type of antibiotic. While in local antimicrobial, we will put the antibiotic agent directly into the pocket, and we can put it in the base of the pocket, make it fit to the base of the pocket. But could it be penetrate to the blood circulation? And this, of course, this needs more. Uh, we will talk now about the systemic antibiotic therapy in periodontitis. Actually, a limited number of antibiotic agents have been tested for use in periodontal therapy. These are include amoxicillin, tetracyclines, doxycycline, penicillins, erythromycin, and nitronitazole compounds. The bacterial plaque is made up of a wide range of species. Therefore, if we want to choose a good antibiotic agent, we have to think about a combination of therapy maybe. So we will make it a wide spectrum antibiotics. Some combinations of antibiotic agents can act synergistically, so to increase the effects of the antibiotic. For example, amoxicillin and metronidazole. This is the most widely used combination in periodontal therapy. Other combinations might act on the other way, act antagonistically, therefore we should not use them together. For example, tetracycline, when it is combined with beta-lactam drugs, for example, penicillin or amoxicillin, or even metronidazole, it will act antagonistically. Therefore, it is not advised or recommended to use tetracycline with penicillin compounds or metronidazole. Penicillins and cephalosporins in general, these are narrow-spectrum antibiotics. They act against a special a special species of antibiotic, but it is bactericidal, a special species of microorganism, but it is bactericidal, so they kill the bacteria. The mechanism of action is inhibiting the cell wall synthesis. Penicillin compounds usually contain beta-lactam ring. This ring can be cleaved by special type of enzymes that can be produced from bacteria, the resistant bacteria to penicillin, penicillin-resistant bacteria. These enzymes, when cleave this ring, which is the effective part of the penicillin, it will stop its action. In addition to that, penicillin might have some adverse reaction to the person. Some people might have hypersensitivity to penicillin. It might range from simple rash to anaphylactic shock, which is serious condition. In addition, we might see some diarrhea and nausea that might occur as an adverse reaction to the use of penicillin antibiotic agent. Amoxicillin actually is the drug of choice in periodontal therapy, and it is a part of the penicillin compound. Uh, why we use amoxicillin more than other types of penicillins in periodontal therapy? Because first of all, it has a considerable activity against pathogenic periodontal bacteria or periodontal pathogens. Secondly, the concentration inside the subgingival or in the gingival clavicular fluid is effective. So it can lead to the effective concentration inside the periodontal pocket. Third advantage is that adding clavulanic acid to amoxicillin make it more resistant against the the beta-lactamase enzyme that will destroy the active ring or the beta-lactamase of penicillin. Therefore, the combination of amoxicillin with clavulanic acid is most successfully used in periodontal therapy. The trade name of it is amoxiclav or augmentin, and different types according to the different companies. Tetracycline compound is made up of the tetracycline, um, the deoxycycline, and the monocycline. And actually, tetracycline, clindamycin, and erythromycin, all of them have some common characteristics. First of all of them inhibit the protein synthesis of bacteria. And all of them are bacteriostatic. They are not bactericidal. And they are broad spectrum antibiotics. Tetracycline actually having a special concern in periodontitis. First of all, tetracycline are capable of inhibiting collagenase enzymes. So they are not acting against pathogenic bacteria alone or only, but in addition to that, they inhibit the collagenase enzymes that occurs during periodontitis. Therefore, it might inhibit the periodontal destruction appears in the area. So this is one of the benefits that we use tetracycline over the others. Also, they have the ability to bind to the tooth surface from where they can release slowly over time. So they can stay in the area for a long time. But it has also adverse reaction. For example, gastrointestinal intolerance, tooth staining, and hypoplasia, especially in children. Therefore, we should not use it in children or pregnant women. Nausea, diarrhea, candidiasis, because of the opportunistic infection, because it is a broad spectrum antibiotic, so uh, it will suppress most of the bacteria in the area. So Candida albicans will opportunistically overgrow and cause candidiasis. And also interaction with contraceptives, and this is an important thing in nitromidazole or nitroimidazole compound. And actually, it has the same characteristic of ciprofloxacin. Both of them inhibit DNA synthesis. This is the mechanism of action. Metronidazole acts on anaerobic bacteria and protozoa only. Therefore, we use it in a combination with amoxicillin to get rid of the anaerobic bacteria. Uh, Importantly, it is effective against Porphyromonas gingivalis, which is one of the important pathogens in periodontitis. This is from the red complex of periodontal pathogens. But it is not effective against Aggregatibacter actinomycetin comitans. We have to consider this as well. Adverse reaction, might be gastrointestinal intolerance, metallic taste, nausea, vomiting, and antabus effect. Generally, in periodontal therapy, there is a wide range of or a commonly used regimens that is more commonly used among periodontists and among dentists as well. It is using of amoxicillin 250 milligram 3 times a day in a combination with metronidazole 200 milligrams 3 times a day as well, and it should be for 7 to 10 days. This is the combination of choice, starting on the day of the first debridement and covering the patient for any other debridement appointments. So if we are thinking of doing another debridement, we have to do it within this period of time, within 7 or 10 days. There are other combinations that we might think about, or the other regimens, for example, using amoxicillin alone, 500 milligrams 3 times a day for 8 days, azithromycin once daily, ciprofloxacin twice daily, clindamycin 3 times daily, doxycycline or minocycline once daily for 21 days. Here, because it is once daily and it is concentration is small. Metronidazole 500 milligrams 3 times a day. The combination, as we said, either metronidazole and amoxicillin or metronidazole and ciprofloxacin. And we have to say it again, do not combine doxycycline, minocycline, or tetracycline in general with metronidazole or with the penicillin. One of the clinical conditions that we might see in the clinic is necrotizing periodontal disease. This is a rare condition, but actually it's worth to know about it and to know how to manage this type of disease. As you see here, it has a unique clinical manifestations of this necrosis in the interdental papillae. The management will include using of metronidazole 200 milligrams 3 times a day for 3 days and then evaluate. In addition to that, remove of the risk factor. Necrotizing periodontal disease is usually associated with smoking, poor oral hygiene, and poor diet. Therefore, we have to motivate the patient about these risk factors and how to stop these risk factors or modify them at least. Why we are using metronidazole here? Because most of the antibiotics or most of the microorganism that is causing this type of diseases, usuospiroketal anaerobes, and the metronidazole is effective against this type of microorganism. Now we reach to the local antibiotic therapy. The main disadvantage are actually when we think about local antibiotic or antiseptic agents, we will think about mouth rinses. But mouth rinses has two main disadvantages in using it for periodontitis. The first one is the rapid wash of the agent, rapid wash out of the agent. The second one is the difficulty in reaching the base of the pocket. If you use it as a mouth rinse, it will be difficult to be reached to the base of the periodontal pocket. Therefore, there are several delivery systems has been tested in periodontal pocket. The test on this delivery system was focusing on the ability to sustain release over a period of time. So it is the ability of staying inside the pocket and released slowly inside the pocket for a period of time. And the second test was effective concentration with remain in an effective concentration within the pocket. And as we said, the gingival trabecular fluid has the power to reduce the concentration or to make the agent reach to its half-life within 1 minute. Some of these systems are available, but some of them are actually not available in all the world, and some of them even disappeared after several tests. The indications of using local delivery system or local antibiotic therapy. When to use it? If we have a periodontal pocket, one isolated periodontal pocket, which is more than 5 millimeters, and we have passed the first phase of therapy, the mechanical or the non-surgical therapy successfully, but we still have this pocket more than 5 millimeters, then we will think about the antibiotic agent, the local delivery antibiotic agent. Secondly, in medical compromised patients who are contraindicated for surgery, for periodontal surgery. Third, patients suffering from recurrent or refractory periodontitis. We are treating periodontitis, reaching to successful results, then after a while it will turn back. And fourth, additionally, as an adjunct to periodontal regenerative procedure. These are the four indications for using local delivery system. We will talk now about the most famous types of the local drug delivery system. Uh, First of all, the tetracycline, or the trade name is the Acticide, as you see here, like fibers inserted inside the pocket. Atridox, or the doxycycline gel, that can be inserted into the base of into the pocket and reach the base of the pocket. Periocline, which is actually aminocycline. Elizole, which is metronidazole gel. And periochip. This is the most widely common periochip, or the chlorhexidine chip. We will start with tetracycline. As we said, tetracycline has the benefit of not acting as a bacteriostatic only, but also it has the benefit of reducing the activity of collagenase enzymes that cause destruction of the periodontal tissue. Uh, Tetracycline here is will come into fibers, periodontal fibers, can be placed as a monofilament of ethylene or vinyl acetate copolymer, uh, and it has a 0.5 millimeter. It is actually a 0.5 millimeter in the diameter, very small, and contains 12.7 milligrams of evenly distributed tetracycline hydrochloride. So if we cut the fibers, we will have the same amount of tetracycline, just evenly distributed along the fiber. The fiber should be inserted into the pocket until the pocket has been completely filled with the fibers. Uh, Actually, we can use the full length of the fiber, or we cut it, because it depends on the depth of the pocket and the contour. Fiber should be placed too closely in contact with the base of the pocket. We have to try to reach the base of the pocket. After that, after we fill the pocket with the fibers, we will close it with appropriate cyanoacrylate adhesive on the top, or we can even use the perio pack or the packs of the periodontal. When placed within periodontal pocket, it provides continuous release of tetracycline for 10 days. So there is a slow and continuous releasing of tetracycline for 10 days. It's a full course of antibiotics. At the end of the 10 days of the treatment, we have to remove these fibers if some of them are still there. Fibers, but we have to check before 7 days if some of the fibers or the fibers has been lost during the first 7 days, then we should replace them and put a new one. Okay. This is about the tetracycline or the acticide fibers. Second type is the doxycycline hyclase. Um, it is actually the same. It is a subgingival controlled release product. Okay, but it is composed of two syringes mixing system. We have to mix it first, and then when it is mixed together inside one syringe, then we can use it. It will be ready to be used, and we can keep it in the refrigerator to be used within 5 days. Uh, if it is not mixed, we can keep it for a longer time. Once it is mixed, it will be ready to use. We can deliver the gel into the pocket by using the syringe, this flow tip, this tip of the syringe, and insert it into the pocket. When this gel be in contact with the environment, with the tissue, it will be calcified. Usually it is contained by 50 milligram of doxycycline hyclase, which is equivalent to 42.5 milligram of doxycycline. The color is usually pale yellow to yellow viscous liquid with a concentration of 10% doxycycline hyclase. As we said, when it be in contact with the tissue or the fluid, the liquid will be solidified and then allows for controlled release of the drug for a period of 7 days. Here we don't need to remove it. It will be removed, it will be degraded by itself. Minocycline can come in different forms. There are gels, there are films and chips and etc. It is minimal inhibitory concentration is about 1 to 2 microgram per milliliter. What does this mean? It means that it should be stay inside the subgingival or inside the gingival fluid in a concentration of 1 to 2 microgram per mil to be effective against periodontal pathogens. It is easy to be loaded in the pocket, and there is a sustained and slow release of the monocycline in the area. Usually we will place 1 milligram of the gel and it will be reduced to 90 microgram per ml in 7 hours. So also it is used once. These are the two types of the monocycline. Here is the periocline, a type of monocycline gel, 2% concentration. And here is the dentomycin, also a periodontal gel made up of 2% monocycline. Minocycline and microsphere. There is a new delivery system made up of microspheres. This system is made to contain 3 milligram polyglycolide lactide polymer, and 1 milligram of minocycline per unit, or the per dose. The polymer is made up of microspheres. These microspheres contains minocycline inside these spheres. When it resolves, it will release minocycline slowly within the periodontal pocket. It's effective. The concentration inside the microsphere is effective concentration, and it will stay in the pocket effective for 14 days. So it is a powder or gel containing more than 100,000 microcells that release minocycline. Usually, after cleaning and root cleaning, we will put this powder or gel in the pocket for 14, and it will be effective for 14 days. As we said before, metronidazole in periodontal therapy is important because it is acting against obligate anaerobes. Both systemically and locally application are effective against periodontal pathogens. So metronidazole has been incorporated as a collagen spore or as a dialysis tubing, acrylic strips or films or even gels for sustained release inside the subgingival area in the treatment of periodontal disease. One of the common types of metronidazole local delivery system is the elizole. Elizole is actually made up of 25% metronidazole in a mixture with a glycerol monooleate and sesame oil. It flows freely on application. It is fluid on contact, but when it will come in contact with the crevicular fluid, it becomes more viscous and more gel-like inside the pocket. And then it starts disintegration and release metronidazole slowly. It can be maintained in high concentration within periodontal pocket for a long time, administered twice with an interval of 1 week. So we will put it inside the pocket for so 1 day, and then after 7 days we will put another dose. This is the elizole that is made up from that's made from the Colgate company. Chlorhexidine. As we said, it is available as mouth rinses, gels, varnishes, or even chips. To be used for periodontitis, we said that before, that mouth rinses will not be effective for periodontitis because it will be washed out very quickly and it cannot reach the base of the pocket. So to be used to treat periodontitis, we have to use a delivery system that make it reach to the base of the pocket. One of these types is perio22, which is a small chip made up, the diameter is about 4.5 by 3.5 millimeters, less than 1 centimeter, made up of biodegradable hydrolyzed gelatin matrix, and it contains glycerine water in addition to the chlorhexidine gluconate, about 2.5 milligrams. The perio22 releases approximately 40% of the chlorhexidine within the first 24 hours, and then releasing the remaining chlorhexidine in a linear fashion within 7 to 10 days. So it stays effective